So very briefly, a little bit of background before we get started. As I mentioned earlier, the regulations were published in the Federal Register on October 4th of 2016. They're being implemented in 3 phases. Phase 1 went into effect November 28th of 2016 and puts into effect most of the regulations, particularly those that continue existing requirements. And Alicia, if you could forward by 2 slides, please. Thank you. Phase 2 of the regulations go into effect on November 28th of 2017 and include some of the new requirements such as behavioral health. With the implementation of Phase 2, CMS is also putting into effect new interpretive guidelines, which they're working on now, and a new survey process that combines elements of the traditional survey and the QIS survey. And then Phase 3, which goes into effect on November 28th of 2019, includes implementation of new programs such as QAPI and compliance and ethics programs. You can see a full implementation schedule of each of the sections on the Consumer Voice website. Our presenters today have decades worth of combined experience and expertise on nursing home regulatory and advocacy issues. We'll hear first from Eric Carlson, Director Attorney with Justice and Aging. We'll hear from Toby Edelman, Senior Policy Attorney with the Center for Medicare Advocacy, and also from Robin Grant, the Director of Public Policy and Advocacy with the Consumer Voice. And with that, we'll start the presentations. Alicia, if you could move forward to the next slide, I will then turn it over to Eric.
Thanks, Lori. And we can move 1 slide forward, please. We talk about assessment and care planning. And just a general comment about the regulations, as you'll see, I think, through each of the presentations that we'll be doing today. Some has changed, but there's a lot of similarity as well. It's still, of course, based on the federal statute, which has been effective since 1990. And so there's a lot of similarity. There's some changes on the margins and a few more significant changes, but if folks on the phone are familiar with the nursing home rules, you'll see a lot of similarities certainly going forward. Although that being said, a lot of provisions that essentially remain the same have been moved from one section to another. So there's some of it, the changes have been new provisions, and some of the changes have been a reorganization of existing requirements. One of the changes that occurs throughout the regulations is an increased focus on person-centered care or resident-centered care, and anyone who works in LTSS these days is very familiar with this concept. The difficulty is in the execution, of course, and where there's a lot more talk about person-centered care. Whether we see a lot of it in practice is another question. To move things forward, CMS now offers this regulatory definition of person-centered care, and you see it's a focus on the resident, and that's the basic requirement, that the care that's being provided, to the extent possible, is not based on facility convenience or standard operating procedures the way it's always been done, but what the resident would need or prefer. Next slide, please. And consistent with that is an accommodation regulation that's very similar to the provision that's been in place forever, pointing out that residents' preferences should be accommodated. There needs to be a reasonable accommodation of what a resident wants, and you'll see here that the standard is actually very stringent, saying that there should be reasonable accommodation, except when to do so would endanger the health or safety of the resident or other residents. So certainly that's something the residents should be aware of, and a facility should not be turning down reasonable requests because they're busy, because it's not the way they've ordinarily done it, but because it would be inconvenience to staff members. You see here the standard is health and safety of the resident or other residents. Next slide, please. And here we'll talk a little more about the care planning requirements. Care, as has always been true, is based on assessment, followed by care planning. One of the critiques about the previous regulatory system was that it allowed facilities to wait an excessively long time for the development of a care plan. If the longest possible amount of time was taken, it would be possible under the old regulations not to have a care plan in place for up to 3 weeks after the person's admission to the nursing facility. So to address that, the current regulations now require, I shouldn't say current regulations, because they're not, this provision isn't in effect yet, but the regulations are going to require that there be a baseline care plan put in place within 48 hours of admission. And you'll see here that this particular provision doesn't become effective until November of this year. Recall that Lori a couple minutes ago talked about phase 1 and phase 2 and phase 3 of implementation. Phase 1 of the regulations already in effect that don't reflect any significant changes from the previous regulatory requirements. Baseline care planning is something that wasn't required before, and because of that, that requirement won't come into effect until November of this year. But it would certainly, facilities would be well advised to start doing that as early as possible. There's no particular reason why you'd need to wait 12 months. It's certainly a good practice to have some sort of functioning care plan whenever a resident is in the facility. You'll note here that the regulatory requirements are focused on the basics, the goals and the various orders relevant to the resident's care. Next slide, please. Which moves us into not the baseline care plan, but a further conversation about the complete care plan. Has to be done within 7 days of assessment. It's based, as it was before, on an interdisciplinary team, which should include, to the extent practicable, the resident or the resident's representative. As you can imagine, it would be hard to, with a straight face, talk about resident-centered or person-centered care if the resident wasn't a big part of the service planning process. And so to emphasize that further and to make sure that the resident participates when at all possible, the regulations now require that if the resident is not participating, that the resident representative is not participating, there has to be an explanation which explains why that is. You don't want, you just want some assurance that the facility and everyone involved do everything possible to make sure that the resident or the resident's representative participates to, again, guarantee as much as possible that person-centered care is a reality and not just a facade. Next slide, please. The interdisciplinary team, the participants are similar to where they were as they were before. The member of food and nutrition staff is a new requirement, and also the mention of other staff as requested by the resident. Next slide, please. And that brings us into the contents of the care plan. It's what the resident needs to get to the highest practical level of functioning. It should, as much as possible, incorporate particular preferences and should not be limited to quote-unquote care. It's daily life, as anyone who is involved with nursing facilities know. It's not a healthcare, exclusively healthcare. It's about your life. And if you're in a nursing facility 24/7, there's a lot of quality of life issues, just scheduling issues and choices and activities and preferences that should be encompassed in a care plan. One other thing that has increased emphasis in the new regulations is the discharge plan. There has to be more of a focus on discharge. There shouldn't be an assumption that once a resident is in the facility, he or she is going to be there forever. There needs to be a look at how what steps are being taken to prepare for discharge out of the nursing facility. Next slide, please. and you'll see that here as well. And you don't want to see a decision where it's just assumed that the resident, of course, will be in the facility forever, and because of that, the regulations require that if discharge is determined not to be feasible, there has to be documentation of why that is and who made that determination. Next slide, please. And just to wrap up this topic, the same advice that we've been given for years still is true, that residents need to be active in this process. It's not helpful to just go to a care plan meeting and say to the nursing facility, well, what do you guys think? The resident and the resident's representative should go in with some sense of what the resident wants, what would be good, and to push things forward. It's a tremendous tool, but it needs to be taken advantage of. And those of us who work in this field need to do as much as we can to support residents and residents' representative in making this process meaningful. So with that, let me pass the conversation over to Robin to talk about some nursing services issues.
Thank you, Eric. So as Eric said, I'm going to discuss what's in the revised regulations related to nursing services, or we just usually refer to this as staffing. And just to clarify, I'm sure almost all, if not all of you know that when we say nursing services, we mean the care that's provided by licensed nurses. So that is licensed practical nurses, LPNs, or in some states they're known as licensed vocational nurses, LVNs, and registered nurses, so RNs. So we've got licensed nurses and also certified nursing assistants, who are usually referred to as nurse aides in the regulations. So I'm going to talk about both sort of staffing levels and numbers as well as training. Next slide, please. So from our perspective, meaning consumer voice perspective, and I would say from the perspective of many other advocates as well, we remain very disappointed that there's been no change in the requirements for staffing levels and numbers. Despite the work of many advocates, we still don't have a required minimum staffing standard, nor has there been any required increase in staffing levels. So I would just note that is a huge concern for us and other advocates. Staffing or lack of staffing remains the biggest problem in nursing homes today. We know that is without doubt the #1 complaint we hear from residents and families and advocates, and we know there's a relationship between staffing and quality care. But the new regulations don't include a minimum staffing standard, nor, as you'll see in a little bit, a requirement for a 24-hour RN. So that's what's not in the regs, but let's look a little more closely at what is in the regs. Next slide. So there are some changes in the regulation relating to staffing, and I felt it was important for all of you to see the actual regulatory language related to nursing services. So here's what the regulation says, and forgive me as I read this out loud. The facility must have sufficient nursing staff with the appropriate competencies and skill sets to provide nursing and related services to assure resident safety and attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident as determined by resident assessments and individual plans of care, and considering the number, acuity, and diagnoses of the facility's resident population in accordance with the facility assessment required at section 483.70 So as you've probably figured out by now, the parts that are in red are new language. Next slide, please. So I just want to make a few points about this requirement. First, like the previous regulation, the revised regulation continues to require that there be sufficient nursing staff. So no change there. But there are two changes that impact what a facility has to consider in determining staffing. So first, there's what CMS is calling the competency-based approach, and that's a new requirement that nurses and CNAs, certified nursing assistants, have to have the necessary competencies and skills to keep residents safe and provide the care that they need to reach their highest possible level of well-being. So when you put that language together with sufficient, you get the requirement that the facility has to have sufficient nursing staff with the appropriate competencies and skill sets. So loosely translated, there has to be enough staff, and that staff has to have the knowledge, the abilities, and the judgment that are needed to successfully and properly care for the residents in the facility. So the question then becomes, how does the facility determine how much staff is enough and what the right competencies and skill sets are? So the answer to that in the regs is that it does that by conducting a facility assessment. So the goal of the assessment is to give the facility a way to determine what resources it needs to competently care for its residents. So this assessment is a new element. It's found in the rules under the section on administration. And CMS is really viewing this assessment as a critical factor in guiding how the facility operates. And I would note that it's, you see reference to the assessment in numerous places in the regulations, not just in the part about nursing services. Next slide, please. So among the elements the facility has to look at to develop the assessment are all aspects of its resident population. And you can see on the slide on the left side what has to be considered when assessing the resident population. And the facility also has to look at its resources. And you can see on the right side this time what those resources are that the facility has to consider. So that means that the assessment, in essence, defines sufficient nursing staff with the appropriate competencies and skill sets. It tells the facility the number of staff it needs, as well as what competencies and skill sets are needed. So this assessment, in CMS's words, is really about the facility knowing itself, knowing its residents, and knowing its staff. Next slide, please. So how often this assessment has to be carried out is pretty much left up to the facility, with the exception that it has to be reviewed and updated at least annually, and whenever there's a significant change. So, for instance, if the facility began admitting residents who needed bariatric care, and it hadn't been providing that care in the past, it would certainly need to update its assessment because its resident population has changed. So before I move on, I want to point out that the facility assessment requirement doesn't go into effect until phase 2. So that's November of this year. So because the sufficient nursing staff with the appropriate competencies and skill sets requirement is tied to that facility assessment, that whole requirement about sufficient nursing staff with the appropriate competencies won't go into effect until phase 2 as well. So just wanted to point out the time frames here. Next slide, please. So the second aspect of staffing that I want to briefly highlight is training. So for the first time, facilities will have to have an ongoing training program for all staff, and the regulation specifically says that that includes existing staff, new staff, and also contract employees and volunteers. So of course, this applies to all staff, but because that includes nurses and CNAs, I wanted to specifically point out this training requirement since it applies here. Next slide, please. So the rule lists some of the topics that have to be included in training, and you can see those topics on this slide. They include communication, residents' rights, abuse, neglect, and exploitation, and more. So one thing I want to particularly note is the requirement that for the first time, all staff will have to be trained in dementia management, which from our perspective is a very good requirement. However, the regs don't say how much training must be provided. That's to be determined by the facility assessment. So again, this underscores the importance of that assessment. This requirement for all staff training on these topics goes into effect in phase 3, with the exception of training on abuse, neglect, and exploitation. And that is already in effect. It was implemented with phase 1. Next slide, please. In addition to the training requirement for all staff, which obviously includes CNAs, the in-service training requirement for nurse aides has been revised in a couple of ways. So first, it includes dementia management training and resident abuse prevention. That must be part of nurse aide in-service training, so that's new. And this part has already gone into effect. And second, when facilities determine what training, what in-service training to provide to address areas of weakness of nurse aides, they have to look at their facility assessment to get a sense of what areas should be discussed and addressed in that training. Right, in the past, they have based training to address areas of weakness solely on nurse aide performance reviews. So now they will have to, or when this goes into effect with the facility assessment, they will have to look not only at the performance reviews, but also at what their assessment is telling them. Next slide, please. So I think Eric referred to, there's some new things, there's some old things. So something old, something new, with a lot of old, frankly. You can see on this slide that the provisions, many of them under nursing services, have stayed the same, such as hiring of nurse aides, posting of nurse staffing information. But one other requirement that, from our perspective, unfortunately has stayed the same is the requirement for a registered nurse 8 hours a day, 7 days a week. And we had, along with others, really advocated for this to be changed to 24 hours a day, but that didn't happen, and I will say that we continue to be very concerned about the lack of the assessment, intervention, and treatment skills of a registered nurse, and we feel that really, those skills need to be available round the clock, and not just 8 hours a day, 7 days a week, and that without having an RN 24 hours a day, residents really are placed at risk. But that is a fight for another day. So with that, I'm going to turn the program over to Toby, who's going to talk with you about unnecessary and antipsychotic drugs. So Toby.
Okay, thank you, Robin. The revised requirements of participation changed the regulations for drugs in some very significant ways. Some of them are good and some of them are not quite so good. Until the revision last year, the quality of care regulations addressed drugs in a subsection called unnecessary drugs. And this section said that residents should be free of unnecessary drugs which it defined as drugs with excessive dose, excessive duration, without adequate monitoring, without adequate indications for use, or in the presence of adverse consequences which indicate the dose should be reduced or discontinued. A subsection of unnecessary drugs in the quality of care requirement of participation was antipsychotic drugs, with two provisions. First, these drugs shouldn't be given to a resident unless they are necessary to treat a specific medical condition which has been both diagnosed and documented in the medical record. And secondly, even then, even if the drug is appropriate, it should be subject to gradual dose reduction. Next slide, please. The revised requirements of participation that went into effect largely in November 2016 moved these provisions to a different requirement of participation. Unnecessary drugs and antipsychotic drugs are now in pharmacy services. This is a concern for a number of us because we thought that the standards of care for facilities should be in a single place, that it makes more sense to have all the standards that facilities need to meet to be in one location so that they could be found easily by residents, advocates, families, and everybody else. However, CMS chose instead to move these rules to pharmacy services. The part of pharmacy services that addresses unnecessary drug prohibitions is identical to the language that we had in the older regulations. So again, unnecessary drugs are excessive dose, excessive duration without adequate monitoring, and so on. A second big change, though, is that the new requirements for the first time address 4 categories of psychotropic drugs, not just antipsychotic drugs, which were the focus of the prior regulations, but also now for the first time antidepressants, anti-anxieties, and hypnotics. On the one hand, it's a good change because we know that facilities, believing they couldn't use antipsychotic drugs, shifted residents to different psychotropic drugs and used them for the same inappropriate purpose of sedating residents and making them quiet. So that's good to have attention to other psychotropic drugs. On the other hand, the change is somewhat troubling because it removes the focus on antipsychotic drugs. And we know that these drugs are seriously misused with nursing home residents, actually for all older people, but we're focused on nursing home residents. There have been reports to Congress for decades about the inappropriate use of drugs like this for residents. Most recently, the Inspector General's report about 6 years ago indicated that practically 90%, if not more, of the antipsychotic drugs are prescribed for residents who have dementia, not a psychosis. The Food and Drug Administration says the use of antipsychotic drugs for residents with dementia can be life-threatening. The Beers list of inappropriate drugs says that antipsychotics are inappropriate for all older people. And CMS has had a campaign for more than 5 years on the misuse of antipsychotic drugs. So there's some concern that some of us have that broadening the attention to all psychotropic drugs, not just antipsychotics, is something of a problem. This expansion of concern to these 4 categories of psychotropic drugs doesn't take effect until November of this year. But the same rules that were applied solely to antipsychotic drugs in the past, not being given unless they're necessary to treat a specific medical condition, and gradual dose reduction, those rules in the revised requirements of participation apply to all 4 categories. Next slide, please. The new rules for the first time also address PRN, or as-needed psychotropic drugs, but the rules are different for antipsychotics and for the other 4 categories. For the 3 new categories of psychotropic drugs, as-needed orders are limited to 14 days, although the physician can document in the medical record why a longer order is appropriate. But for antipsychotic drugs, an order for more than 14 days of as-needed antipsychotics is appropriate only if the physician evaluates the resident. And in the discussions about the interpretive guidelines that will give further meaning or further explanation of the regulatory language. We had a lot of discussion about what evaluation means, whether it means an in-person examination by the physician or not. We don't know how CMS is going to come down on that issue, whether an in-person examination is required for those PRN orders for antipsychotics exceeding 14 days. Next slide, please. The preamble gives us some additional information about the public comments that were submitted on the proposed regulations and how CMS responded. For example, CMS declined to adopt regulations that it had proposed in 1992 but never made final because CMS says now that they're too prescriptive. And it also indicates in the preamble that it accepted the public comment to extend the duration of PRN orders for psychotropic drugs from 48 hours, which is what CMS had proposed, to 14 days, because some facilities felt this, or at least there were a number of public comments saying it was burdensome to have only a 48-hour period. Next slide, please. A second part of the drug regulation is drug regimen review. And as before, a licensed pharmacist must review each resident's drug regimen each month. Next slide, please. What's new is first, beginning in 2017, the pharmacist must look at the medical record as part of drug regimen review. That's a good change, of course, and it should improve pharmacists' ability to evaluate the appropriateness of drugs that are prescribed. A second new change is that the pharmacist must advise the medical director of any irregularities that are found in the resident's drugs. Until these rules, the pharmacist was required to inform only the attending physician and the director of nursing. So this is a good change if the medical director is actually an independent person and not the attending physician for all of the residents, in which case it would just be a redundant requirement. But the third change, that's also quite important, is that the physician must document that he or she reviewed the pharmacist's report and made the changes that were recommended or explained the rationale for not making changes. And in the past, I think physicians could ignore the pharmacist's recommendation without explaining why. So this could also be a very important change. Next slide, please. Another new requirement is that facilities must have policies and procedures for drug regimen review. Next slide, please. And the preamble gives some additional information or understanding about what CMS thought and the decisions that it made. So one concern we had was that CMS declined to require the independence of the consultant pharmacist, which it had proposed back in 2011, but declined to make final in 2012, saying it would look for additional information. Some of us hoped that in these new requirements of participation, the independence of the consultant pharmacist would be confirmed, but that did not happen. So I think there are some very important changes here, but it's also important for residents and their families and representatives and advocates to be vigilant and to use the tools we have. It's important to stay involved in the drug prescribing because, as I mentioned, we know antipsychotics are inappropriate for most residents. So unless a resident has a long-standing psychosis and the antipsychotic drugs are medically appropriate for that individual, it's important to question if a resident suddenly gets antipsychotics prescribed, or suddenly, as we've heard happening and seen in survey reports, the resident suddenly gets a new diagnosis of psychosis to justify use of an antipsychotic drug. So it's important to stay on top of these issues. Secondly, even though the regulations on drugs don't explicitly say that residents have the right to give informed consent to specific drugs, the rules and the preamble make very clear throughout that residents have a choice and control over their health care, all aspects of their health care and aspects of their lives, and this, of course, includes drugs. So finally, we would encourage people to make sure that assessment and care planning includes discussion of drugs. Residents and their families and advocates should not hesitate to use the process, as Eric described at the beginning of this webinar, to understand the drugs that are being prescribed, to question the appropriateness of these drugs, and to say no to drugs that should not be prescribed. So Eric, back to you for transfer and discharge now.
Thanks, Toby. Let's start with the 6 reasons for transfer discharge. These are familiar to anyone who's done nursing facility work. The red language here indicates some changes that are made. So the standard 6 reasons that everyone are familiar with. The first change noted here is that the safety of others is purportedly limited by the requirement that this applies only when this endangerment is due to the clinical or behavioral status of the resident. Although I've got a note here that I don't know how much limiting that actually does, that in most cases when supposedly the safety of others in the facility is endangered, the allegations relate to the clinical or behavioral status of the resident. The second change is likely more useful. This is a provision that in the past was in the surveyor's guidelines and now has been upgraded to the regulations. And it states that there can't be an involuntary transfer discharge for non-payment if the resident has submitted the necessary paperwork to a third-party payor. And this most frequently comes up in situations where there's a pending Medicaid application. And when that happens, the facility cannot move to force the resident out for non-payment. The Medicaid application the processing has to be allowed to go on to its conclusion, which of course is completely fair to the resident in that situation. Next slide, please. This is something that's new and is likely to be useful, I think. A lot of times you see allegations by facilities that they can no longer meet the residents' needs, and in my experience, in my opinion, it's oftentimes cited in situations where the facility really could. The resident may be difficult, the resident may be heavy care, there may be some complications in providing care, but there's nothing about that resident that says his or her needs cannot be met in a nursing facility. And in practice, I think you see that demonstrated all the time, because nursing facility A will propose transferring the resident to nursing facility B. And so then the argument to the first nursing facility always goes, well, if the second nursing facility can deal with this person, why can't you? And this requirement addresses that. If a facility alleges that it can't meet the resident's need, the record's got to include the specific need that purportedly cannot be met. There has to be documentation of attempts by the nursing facility to meet the resident's needs, and a listing of the services available at the receiving facility, nursing facility number 2, that allows that facility purportedly to meet the resident's needs. I'll note another regulatory requirement here. There's a separate provision of the regulations that at admission requires the nursing facility to provide notice of, quote, the special characteristics or service limitations. I know that that language seemed a little dangerous to me and others that do this kind of advocacy, because it seemed to give the facility some encouragement to supposedly limit the services that it provides, possibly below that from what should be required by law. But in this particular circumstance, it might be cited useful by residents. If a facility is arguing it can't meet the resident's needs, one argument by the resident's representative could be, look, you didn't say that at admission. We would have no way of knowing that you supposedly cannot meet this particular need. You were required to give us notice at the front end of any service limitations you have, and you failed to do so. Next slide, please. Some new protections. The first one, I think, was the way it usually worked in any case, or the way it should have worked in any case, that people shouldn't have been transferred out while their appeal is pending. and the regulations now explicitly say that. They're skipping down to the third bullet point there. The facility has to assist the resident in completing the form, so not to prosecute the appeal, of course, because the facility can't be arguing against itself, but just to provide logistical assistance in getting the transfer discharge appeal filed. And then finally, going back to the middle bullet point, the facility now is required to send a copy of the transfer discharge notice to the long-term care ombudsman program. And this does not require the resident's consent. The facility should just be doing it in every instance. And the idea being that residents need some support and they need some information, and too frequently residents, when they get a notice, they're scared, they don't know particularly what to do, they're intimidated by the whole process, and they just pack up and move away. If the notice, on the other hand, goes to the ombudsman program, the ombudsman program can speak to them, counsel them, give them some suggestions, give them some support, and help them through this process. There's been a fair amount of conversation, I think, prompted by this requirement, looking into when notice has to be required. I had an inquiry about this just within the last hour and a half, and or 2 hours, and I think that because of this requirement, there's been some concern that ombudsman programs will get buried in all these notices, and that facilities have to give notices every single time a resident ever leaves a facility, whether it's involuntary, moves out of the facility, whether that's involuntary or not. And that's never been true in my experience. That when their facilities have never been giving these kind of transfer discharge notices when a person just chooses to go back home or to move elsewhere. The operative provision, which is still operative, it's a provision in the interpretive guidelines that says that the involuntary transfer discharge rules apply, quote, to transfers or discharges that are initiated by the facility, not by the resident. Whether or not a resident agrees to the facility's decision, these requirements apply whenever a facility initiates the transfer discharge. So that's been the standard in the past. It remains the standard. So if if a facility initiates the transfer discharge, if they give out a transfer the notice that says you have to get out, or if they say, look, you have to get out, or if they say your Medicare stay here is ending, you don't have a right to stay here anymore because we only want you here under Medicare. Whatever it is, whenever it's being initiated by the facility, then the facility has to give that notice, and appropriately has to then include that notice to the ombudsman program. If, on the other hand, the move is from the resident's initiative, then it's not an involuntary transfer discharge, and this process is not initiated. Next slide, please. There's some improvements here on the returning to the facility after a hospitalization, for example, that, as has always been true, the facility has to give notice of a bed hold policy. Also, as has always been true, if the resident is Medicaid eligible, the resident has a right to return to the next available room in the nursing facility, regardless of the length of the hospitalization and regardless of whether there's been a bed hold. So if I'm in a hospital for 6 weeks and I want to get back to the nursing facilities, the Medicaid program hasn't paid for an empty room for 6 weeks, but I'm entitled to get back to the next available space. And if my old room is available at that point, I have to be allowed to move back there. Next slide, please. And then there's some good language, I think, in most situations about preventing this resident dumping, where the resident goes to the hospital and the facility says we don't want to take you back. It's essentially a lockout. And in most advocates' opinions, an evasion of the transfer discharge rules. Rather than going by following the process, the facility just says we're not taking you back, which puts an incredible burden on the resident who's likely in a hospital that doesn't intend to retain him or her for more than another day or two. So the language is better in this case. It makes it clear that if a facility makes a claim like that, the facility has to comply with the transfer discharge regulations. And I would suggest that means that when you've got these kind of situations and the facility claims that it can no longer meet the person's needs, or there's non-payment or whatever the reason is, and those allegations are made regarding a resident who's currently hospitalized, the obligation of the facility is to readmit to accept the return of the resident and continue with the process. That's what this says. And also, you recall that regulatory provision we talked about a couple minutes ago that says there can't be a transfer discharge carried out until the appeal process is complete. And all of that, and just basic fairness to the resident, suggests that if there's allegations by the facility cannot take advantage of a hospitalization and instead has to give the proper notice and allow the resident to return and to follow whatever appeal processes that may be available to him or her. Next slide, please. Just very quick rules. These are the same tips I would have given 6 months or a year ago. Don't move out. If you can't tell you how many times residents panic, move out, and then call up and say, "Oh, I think that was inappropriate." Well, it's a little late at that point. People need to hang in there and go through the appeal process. The law is actually very good. The administrative hearing officers may vary in their inclinations from state to state or county to county, but the law is really strong and in favor of residents. And it's appropriate to look at what the facility needs to do. Go back and look at that care planning process. You shouldn't be blaming a resident with dementia for behaving in certain ways when that kind of behavior is just expected, a completely normal way of behaving. If you have Alzheimer's or some other dementia, there should be some burden on the facility to care plan for that, rather than claim that they're incapable of providing the appropriate services for some reason or another. So with that, why don't I pass the program back to Lori, and we'll address maybe another issue or two and field some questions.
And so let's now turn to some questions, because lots have been coming in. So there were a number of questions related to transfer and discharge issues, particularly around the Ombudsman program notifications, and Eric did address that some. And I guess the other thing we'll say about that is CMS is very aware of some of the challenges that are being addressed with that issue right now, and is working on its guidance, and are looking to actually send out the guidance fairly quickly, since they know that Ombudsman programs are being inundated with notifications, and there's confusion among facilities and also programs as to what needs to be sent to the Ombudsman. So, okay, let's go to a couple other of these questions. One question relates to whether, sorry about that. One question with respect to antipsychotics and psychotropic medications is around whether the rules apply to antipsychotics for hospice patients. And I don't believe the rules specifically talk about that, but does anyone want to address that question?
I don't think that there's any, this is Toby, I don't think there's anything separate in the regulations that says hospice, residents who are in hospice either do or don't get antipsychotics. I don't think there's anything separate in there. Maybe something will come up in the guidance documents, but I don't think in the regulations. Does anybody else Think the regulations have something to say about that?
Not that I'm aware of.
No, I don't think so either. Okay. Another question is, how does a resident challenge the assertion that their condition or behavior presents a danger to others as we think about the reasons for transfer or discharge?
This is Eric. Nothing's changed there. That you just you put out evidence that the person is not a danger, or maybe flip it and demand that the facility present their evidence that supposedly shows that the person is a danger. In my experience, a lot of these are overblown. That you've got it's a resident who's physically frail with Alzheimer's that lashes, swings his or her arms around a little bit. Anyway, that sort of thing. I think the point is to put the onus back on the facility to back up these allegations, to emphasize that facilities are set up or should be set up to care for people with dementia, and also to look back on the care planning process. That oftentimes there's a deficit there. The first response in all these situations should be care planning, to try to figure out, to find solutions, and the facility instead moved to involuntary transfer discharge first. That's getting things backwards.
Thanks, Eric. There's been a couple questions. Oh, go ahead, Robin.
I was just going to add that the requirements for training around dementia, well, they phrase it as dementia management, I think should help in defending some of these proposed transfer discharges. So hopefully that's another tool that people can use.
Good.
Great. Thanks, Robin. There have been a couple of questions about the assessment and care planning process around residents' rights to exercise preferences, whether it be the right to refuse treatment or also preferences that the facility does not agree with, such as maybe diet or smoking or other types of references. So would any of you want to address that questions around resident preferences?
This is Eric. I think the residents' rights still are in play. So I know that I cited the language that said that there doesn't have to be a reasonable accommodation if there's a endangerment risk, but that doesn't change the right of the resident to refuse treatment. So and that would trump in that situation. That's the right that would take precedence in that situation. And regarding some of the other situations, it is reasonable accommodation. And when you talk about what's reasonable, there's some balancing there. But in general, the resident has a right to do things, and if the only negative consequences are to that resident, that should be within the resident's control, not the facilities. Now, if the resident's choices affect other residents negatively or are an undue burden on the facility in some way, that's something else. But if the purportedly negative consequences fall only on that particular resident, in general, that's a decision that the resident can make.
Thanks, Eric. There have been a couple questions also about the question of discharge for non-payment and how it applies to a resident who is competent and takes care of their own finances and just refuses to pay their share of their bill.
Well, if you refuse to pay, you lose. That's I think the short answer.
Yeah.
That's it. That if you don't pay, it's non-payment.
Yeah. The question about the issue related to hospital dumping, there have been a couple questions about facilities that refuse to accept a resident back from a hospital stay.
Yeah, that this is Eric again. That the difficulty here is in the mechanics, because if the resident's in the hospital, the clock starts ticking, and if the licensing agency isn't prepared to take quick, aggressive steps, then things are very difficult for the resident. There's a handful of states, California is actually one of them, that specifically have administrative hearing procedures to deal with this situation, really expedited procedures. But in the absence of that, it can be difficult for residents and their advocates, and you need to hustle and complain and agitate and get the licensing agency on your side, or file a lawsuit and get a temporary restraining order, or enlist the hospitals to push back against this and object to essentially being a dumping ground, or some combination of all those things. But that being said, I think we all recognize that the logistics of it are difficult. The regulation is not self-enforcing. We've got more tools than we had 6 months ago, but it still really takes some work when you've got these situations.
Thanks, Eric. So we are at the end of our hour for today. I will say that for the topics that we covered today, issue briefs have been prepared by our 3 organizations. They've been loaded into your control panels for the webinar and can be downloaded from there, but we'll also send around to all participants links to the issue briefs, as well as the recording of today's presentation and the PowerPoint that's available for today. Hopefully the issue briefs will address a number of the questions that have come up. Feel free to call or email us directly with your questions, and we'll be happy to try and help you as best we can, and we'll be continuing also to release additional resources and information over the next few months on different areas of the regulation and different topics. So with that, we'll close for today. I'd like to thank Eric, Toby, and Robin for your excellent presentations, and we'll look forward to talking with you next time. So with that, we'll close today's call.
Thanks, Lori.